Hello, so today we will discuss about the diabetes. It's a vast topic and it's difficult to cover in one lecture, but I will try to remain as precise, as concise as possible and try to cover the simple basics of the diabetes and avoid going into the too deep details. So it will be more helpful at undergraduate study level. Now, what is diabetes? Diabetes is a chronic condition that is characterized by raised blood sugar. So, whenever there is hyperglycemia, we think of the diabetes. The regulation of the plasma glucose we all know is because of the insulin and glucagon. Whenever the insulin reduces and whenever the counter organs, that is glucagon, epinephrine, cortisol, and growth hormone increases, there is a hyperglycemia. So the regulation of the blood glucose by the insulin is done by this, that whenever there is a high blood glucose, the pancreas gets the stimulus and it secretes the insulin. The insulin enters inside the blood circulation. It goes to the muscle. It goes to the adipose tissue where the glucose enters inside and it is removed from the blood cells. Same way, it go to give signal to the liver so that the glycogen synthesis increases. There is more glycogenesis and the glycogen is stored and glucose is removed from the blood system. Whenever the insulin is low and glucagon is high, the reverse process starts. The muscle, the glucose can't enter inside the muscle. The muscle amino acid starts degradation. It enters inside the liver and is converted into glucose in the process what we call gluconeogenesis. There is increased fat lysis, what we call lipolysis, and there will be more free fatty acids inside the blood circulation. So there are two main types of the diabetes. If we talk about the classification, type 1 and type 2. Type 1 is autoimmune diabetes. That is because of the autoimmune destruction of the beta cell, and it is totally insulopenic diabetes. There is zero insulin. It was also called insulin dependent diabetes in the past and juvenile diabetes in the past, but now these two terms are not much used. Only the type 1 is used. Type 2 is the insulin resistance, which is happening at the older age, and it is not because of the insulinopenia, but it is because of the resistance of the insulin. The insulin is not attaching to the receptors properly, and therefore the glucagon is not entering inside the cell and remaining in the blood and causing the hyperglycemia. It was previously called NIDDM, non-insulin dependent diabetes mellitus. Now this term is not much used. Adult onset diabetes still used, but type 1 and type 2 are the main names which are given to these types of the diabetes. Third is the gestational type of diabetes. A normal patient who becomes pregnant and diagnosed with diabetes, we call it a gestational diabetes. This is a pre-diabetic condition. This patient may deliver a baby and becomes neuroglycemic without any treatment, and if no proper action of lifestyle modification and drugs like metformin is given to the patient, this patient will end up into a frank diabetes after a few years. A patient who is already diabetic, a known case of diabetic becoming pregnant, is not a gestational diabetes. That is called a diabetes with pregnancy, or a pregnant patient having diabetes. Gestational diabetes is particularly a term used for a pregnant patient detected having diabetes for the first time in life. Other types are secondary DM, we will see it later on. Now, etiology of the type 1, it is autoimmune disease. There is a genetical predisposition of a patient, and there is an environment and insult. And when these both to combine, they destroy the beta cells by T cells, and the antibodies they are directed against the B cell. We don't know the exact cause, but some of the causative factors are speculated. Viruses like Coxsackie, mumps, rubella, the nutrients like cow milk. If the child is put on cow milk in a very early stage, this cow milk's antigen, it mimics the beta cell antigen, and the antibodies directed to the cow milk may destroy the beta cell like a molecular mimicry of the rheumatic fever. The etiology of the type 2, there is impaired insulin action. We don't know the exact cause, but the impaired insulin action will cause more glucose production from the liver and more glucose production from the muscles and fat tissues, and there will be under glucose utilization. The glucose cannot enter inside the cell, and therefore there will be hyperglycemia. Ultimately, as the type 2 diabetes progresses, as the span of the disease is longer, then the beta cells dysfunction starts. Because of the impaired insulin action, initially there will be hyperinsulinemia, there will be too much insulin production, but still the receptors are not responsive. So gradually the beta cell will be exhausted. There will be loss of beta cell mass also, as well as the functional capacity also. The beta cells are reduced in functional capacity as well as in numbers. This will lead to impaired or decreased insulin secretion, causing the hyperglycemia. Now, the response to insulin is decreased because of the reduced glucose uptake by the muscle fat and increased glucose production by the liver, as we saw previously, and this will cause the hyperglycemia. So, reduce insulin, there will be inhibitory effect on glucagon secretion. Glucagon will rise. This glucagon will stimulate liver to do the gluconeogenesis. The amino acids coming from the muscles are converted into glucose, and glycogenolysis. The glycogen is converted into the sugar, raising the blood sugar level. In the muscles, the reduced insulin, there will be reduced glucose and amino acid uptake by the muscles. So more glucose will remain inside the blood. We will call the hyperglycemia. Increased plasma glucose and increased plasma amino acid level. In the adipose tissue, reduced insulin will cause lipolysis, reduce lipogenesis, and this will increase the free plasma fatty acid levels. So if we see the characteristic difference between type 1 and type 2, the number of patients of type 1 diabetics are 5 to 10%, while in type 2 are more than 90%. So most of the patients in the world are having type 2 diabetes. Pancreatic function is usually none. There is almost zero production of the insulin in type 1. Pathogenesis, type 1 is autoimmune process, while type 2 is defect in the insulin secretion and the insulin resistance. There is some problem at the receptor level. There is a strong family history in the type 2 diabetes. In type 1, it is not strong. Genetical predisposition is there, but the hereditary factor or the family history is not there in the type 1 diabetes. Obesity is uncommon. Type 2, it is a common. The metabolic syndrome, the syndrome X, obesity is one of the factor of causing the diabetes type 2. History of ketoacidosis is often present. In type 2, it's rare, except in stress like surgery or infection, the patient go into decay. Clinical presentation, moderate to severe symptoms. Type 1s are always symptomatic. Severe weight loss, polydipsia, polyphagia, polyuria, fatigue, and ketoacidosis. Type 2, so many patients are asymptomatic. Most of the patient presents to you with pre-operative assessment or a job placement, physical fitness, and suddenly, or a patient going for a cataract surgery or dental extraction, and patient is screened and suddenly hyperglycemia was found out and the patient was diagnosed as diabetes. Because most of the time, more than 30% of the patients are asymptomatic. So polyuria, fatigue, mild symptoms, and they are mainly diagnosed on routine physical examination. Treatment of type 1 is mainly insulin and diet, exercise. In type 2, diet, exercise followed by oral hypoglycemic agents, and then we can think of the insulin. Insulin is always has to be considered in each and every patient of type 2 at one or other state, because there will be steady decline of the beta cell function. So a stage will come that even in type 2 you have to give insulin to the patients. Risk factors type 1, as we discussed before, genetic predisposition with virus and exogenous toxin which triggers autoimmune response which destroys the beta cell. In type 2, the risk factors are family history. Maternal or paternal family history should be taken very, very carefully. Uncles, aunties, and father, mother, they all have some history of diabetes in the family. Obesity runs in the family because no one runs in the family. Habitual physical inactivity. No one has fond of exercising. Previous identified impaired glucose tolerance or impaired fasting glucose. If the patient has history of impaired glucose tolerance in past or impaired fasting, we will see what this term means. Whenever there is impaired glucose tolerance, means the patient has developed the process of development of diabetes. If the impaired glucose tolerance was there in the past, it is risk factor for diabetes. If proper lifestyle measures are not taken, if drugs like acarbose or metformin not started, this patient will end up into a diabetes within few years. Hypertension and hyperlipidemia are also are the risk factors for the diabetes. So metabolic syndrome you can diagnose with some clinical measures. If we measure the abdominal obesity, now the BMI is not considered. In men, waist more than 102. In women, waist more than 88 centimeter. That is 40 inches in men and 35 in the female. So XL size of trousers. Triglycerides of more than or equal to 150. High density lipoprotein in men less than 40, women less than 50. Blood pressure of more than 130/85, and fasting glucose are more than or equal to 110. When these criteria are met, the patient is having syndrome X, the patient is having metabolic syndrome, and there are all the chances that the patient will have diabetes in near future. Other things which you can look for in a patient are the skin tags or in the axilla or in the necklines, the fatty liver on the sonography. This all means that this patient is having a metabolic syndrome, or what we call the syndrome X. The carbohydrates are metabolized in the body to glucose. The CNS uses this glucose as primary energy, but other tissues need the insulin. Without the insulin, the glucose will not enter inside the cells. The postprandial glucose metabolism in normal individuals, after food is ingested, blood glucose concentration rises, and this stimulates the insulin release. Now, this is an incretin effect. This was discovered when the patient was given an oral glucose tolerance test and IV glucose tolerance test, and it was found that oral glucose was stimulating more insulin release than IV glucose. So some mechanism is there in the gut, which is sensing the rise in the glucose level in the gut and stimulating some substances to increase the insulin release. And this is how the incretin story started. We will see it later on when we will talk about the management of the diabetes. So insulin will do these actions. It will increase the glucose uptake by the tissues. It will increase the glucose uptake by the liver. It will convert the glucose to the glycogen in the liver, and it will reduce the glycogen breakdown. So it will increase the glycogenesis and it will reduce the glycogenolysis. It will increase the lipid synthesis and inhibit fatty acid. It will reduce the lipolysis and break down to the ketone bodies. And it promotes protein synthesis, and it will retard the gluconeogenesis, and it will also retard the protein degradation into amino acid. Therefore, it is an anabolic hormones. Now, if we see the pathology of the type 1, it is absolute deficiency of insulin due to the autoimmune destruction of the beta cell. Uh, these are the beta cells, and if you see in the type 1 patients, there are almost no beta cells in the pancreas. They are destroyed by the autoimmune mechanism. So there are four stages. First, appearance of the autoantibodies. Suppose this patient has a Graves' disease or a pernicious anemia or other autoimmune disorders, and you screen for a islet beta cell antibody, then this patient might be screened positive before the diagnosis of type 1 diabetes. Then they enter inside the hyperglycemia phase when 80 to 90% of the beta cells are destroyed. Beta cell produce insulin until their population are at around 10 to 20%. But after the 80 to 90% are lost, the patient develops hyperglycemia. Then there is a transient remission. The patient achieves some euglycemia because of the insulin production increased by these beta cells. The autoimmunity is suppressed for a few times. This is called the honeymoon phase, and then again patient develops into the frank hyperglycemia. So this is how the insulin is gradually declining because of the reducing beta cell mass. Then there is a phase when the euglycemia is achieved, or less insulin is given from the exogenous sources, and the patient's insulin requirement reduced. This is called the honeymoon phase, which lasts for few months, and then again the patient gets the frank hyperglycemia or can go to the ketoacidosis. Type 2 is characterized by presence of both insulin resistance and some degree of insulin deficiency. As I told you, the beta cell mass will gradually decline. The type 2 occurs when a diabetogenic lifestyle, excessive calories, inadequate caloric expenditure, and obesity superimposed upon a susceptible genotype. So whenever there is a familial history, whenever there is hereditary factor, and this patient copes up with too much calorie intake and less calorie expenditure, no exercise, and too much of junk food, this patient will end up into a type 2 diabetes. As you can see here, the glucose gradually rises. This is the fasting glucose, this is the postprandial glucose, and here somewhere the patient is diagnosed having a diabetes. But at the time of the diagnosis of the diabetes, you can see that the 50% of the beta cells are lost at the time of the diabetes. So the process of the diabetes starts decades before the diagnosis of diabetes. So this is the part where you can intervene if the lifestyle changes are measured or followed legitimately, if the patient loses some weight, if he cuts down the calories, if he starts exercising. This is the phase where there can be a reverse gear. The patient can go back, and the patient might not develop diabetes in the future. Now, laboratory test, mainly in the previous time, the glycosuria, that is the urine sugar, was measured for diagnosis. Now it is not measured. The ketone is measured to diagnose a diabetic ketoacidosis. The fasting, the random plasma glucose, the postprandial is the PPBS. The post meal is mainly, we are talking about the post meal only during the management of the diabetes, not during the diagnosis, because in the diagnostic criteria there is no importance of post meal sugar. Main criteria are fasting, any random sugar, and the glucose tolerance test. 75 gram of glucose is given to the patient in a fasting state in a 300 ml of water, and the patient sample is taken at 1 hour, 2 hour, and 3 hour. So these are the tests, and we will see the diagnostic criteria. The HbA1c, this is a glycated hemoglobin. The hemoglobin is combining with the glucose in a non-enzymatic process. The half-life of RBC is 120 days. So whenever you measure the glycosylated hemoglobin, it will give you 12 weeks total average control of the diabetes. So this is a very good tool diagnosis as well as in the monitoring of the diabetes. Fructosamine is also used. This is a glycosylation of the serum protein. Uh, the serum albumin has shorter half-life than the hemoglobin, so therefore it gives you a 2 weeks control of the diabetes. Not much used in the diagnosis, but it is used in the management and to see the glycemic control of the patient. So the tool to stem the patient having a diabetes or pre-diabetes are the HbA1c 6.5 or above is diabetes, 5.7 to 6.4 is pre-diabetes, and normal is about 5. So a patient below having HbA1c of less than 5.7 is euglycemic, not diabetic. 5.7 to 6.4 is pre-diabetes, and 6.5 or above is diabetes. Same way, fasting 99 or below is non-diabetic. 100 to 125 is pre-diabetes, and 126 or above is diabetic. The oral glucose tolerance test, 2-hour sample after 75 gram of glucose. If it is 139 or below, patient is not diabetic. If it is between 140 to 199, patient is pre-diabetic. And if it is 200 or above, then the patient is frankly diabetic. So 3 tools we are using to diagnose the diabetes are HbA1c more than 6.5, fasting more than 126 or equal to 126, and second sample of oral GTT 200 or above. These are the 3 diagnostic criteria of diabetes. There is no mention of post-meal glucose. Post-meal 2-hour glucose is not used as a diagnostic criteria for diabetes, but rather it is used to monitor the glycemic control in a pre-existing diabetic patients. So HbA1c, fasting, and oral glucose tolerance 2-hour sample. These are the 3 criteria are used to stem the patient as pre-diabetic or diabetic. Now, self-monitoring of the blood sugar with this glucometers is now a trendy thing, and it is a very convenient thing because the patient doesn't have to go to the labs, doesn't have to get the phlebotomies repeatedly. He just have to do the puncture of the finger, and the finger prick capillary blood is measured by these glucometers. Now, these are very convenient, but always remember that there will be always 10 to 20% difference between the capillary blood sugar and the venous blood sugar. This will be a bit higher, and this will give you a rough idea. If your blood sugar is 150 here, then it means that the patient's blood sugar can be between 140 to 170. So this is for a rough idea, and you get the range. The fixed figures are not important. And there are so many brands of blood sugar glucometers are available. And in India, One Touch, AccuCheck, these are Prestige, Precision. These are some of the brands which are reliable, and they are giving very good readings. Another thing is the continuous glucose monitoring system. The Freestyle Libre or Dexcom, these are the meters which are attached to either arm or abdomen. These are the plungers with which that this sensor are attached. There is a stickers like this which attach to the skin. These remains active for about 14 to 10 to 14 days depending on the sensors. These sensors, you can have these readers which by the help of NFC can read this Libre and give you this graph. Some of the meters like Dexcom can give you a real-time sugar. Some of like Libre doesn't give you a real-time sugar. It will give you only graph. But these are very important because this measures the interstitial blood sugar. It doesn't measure the blood sugar, but it measures the interstitial sugars, which are almost equal to the blood sugar. In the past, they needed calibration that you have to do the blood sugar. You have to enter inside this. It will see what is the difference between the sugar measured by this sensor and the sugar measured by the glucometer, and will interfere the report. But now these sensors, they don't need calibration, and the reading is almost equal to the glucometer readings. Why it's important? Because so many times there is something called glycemic variability. The patient can enter inside the hypo, then suddenly hyper, then hyper. This too much of glycemic variability makes the patient prone to CV diseases. These patients are more prone to have myocardial infarctions or CV strokes. Suppose a patient is maintaining a blood sugar of around 150 or 170 or 180, and then some other patients having 240, then 230, then 30, then 250. If you measure the HbA1c of these both patients, they will be equal. So HbA1c can misguide you, but if you put this CGM as continuous glucose monitoring system, this will give you a very good data of glycemic variation happening. So according to them, you can advise the patient about lifestyle changes, diet changes, and you can change the medications or insulin dosage accordingly. So this is a very good tool, and now it's becoming more and more used by the clinicians and patients in clinical practice. Now, clinical presentation of the type 1 is polyuria, polydipsia, polyphagia, weight loss, weakness, dry skin, and ketoacidosis. In type 2, patient can be asymptomatic. As I told you, more than 30% patients are asymptomatic and mostly diagnosed during routine screening, pre-op assessments, or job assessments. Polyuria, polydipsia, and polyphagia are also common. Fatigue, weight loss. Most patients are discovered while performing urine glucose screening or blood sugar screening because for some assessments. Now, treatment, we want the relief of the symptoms. The patient should be relieved of polyuria, polydipsia. The patient should be relieved of weight loss. Patient should gain some weight. There should be reduced mortality. There should be good quality of life. The patient should not die of any complications. We will see the retinopathy, nephropathy, neuropathy, etc. in the coming slides. There should be improved quality of life. Whenever you start the treatment, in any disease, your aim should be to give better quality of life. We don't want to just lengthen the life, we should give the quality of life too. Reduce the risk of microvascular and macrovascular complications. Macrovascular complications are coronary heart disease, stroke, and peripheral vascular disease, and microvascular complications are retinopathy, nephropathy, and neuropathy. Now there is something fishy here. If you do very tight control of diabetes, suppose you keep your blood sugar around post meal blood sugar around 130, then this patient will not have microvascular complications. That is, the patient will not have retinopathy, will not have nephropathy, will not have neuropathy. But you are achieving this control at the expense of too much hyperinsulinemia, either endogenous or exogenous. You are controlling his blood sugar level by giving too much of OHs, oral hypoglycemic agents, or you are giving too much of insulins from outside. So you are controlling the blood sugar by achieving a hyperinsulinemia, and this hyperinsulinemia can cause macrovascular complications. So patient who is having high insulin will have more coronary artery disease, more stroke, and more peripheral vascular disease, gangrene, etc. So it's important to achieve a balance. So many trials have shown, the Wikipedia trials and other trials, that you don't become too much tight control centric. You remain a liberal control centric. That we will discuss later on. We will talk about the control of the diabetes. But you remain liberal. Don't become too tight. Whenever the patient is too tightly controlled, there will be too much of hypoglycemic episodes, and each hypoglycemic episode predisposes the patient for severe mortality or severe morbidity so many times. So a patient having hypoglycemia, there are all the chances patient will develop stroke or MI within next few weeks. So avoid hypoglycemia and achieve euglycemia. That should be the goal of a treatment of a diabetes. Now, how to achieve the goal? Near normal glycemic control reduces the development of the microvascular disease, and control of traditional CV risk factors such as smoking, dyslipidemia, intensive BP control, and antiplatelet therapy. Now, these all are multifactorial. This is not that you achieve the blood sugar control of 120 or 130 postprandial, but the patient's BP is 200 by 100. Then the patient will have a severe stroke. You achieve the good glycemic control, but lipids are high. The LDL is around 200. Then the patient will have ISD, MI, or stroke. So this is a multifactorial problem. You have to address each problem. You have to achieve euglycemia. You have to achieve a good control of the blood pressure. You have to get your LDL to an optimal low level. You have to educate the patient to lose the weight. You have to educate the patient to stop smoking, reduce alcohol consumption. So when all these things are done together, then and then your treatment will give the results. So the general principles are medication, dietary and exercise modification, regular of complication monitoring, self-monitoring of blood glucose, and control of BP and lipids. So treatment, tablets and injections, because we are doctors. But at the same time, we should be a holistic doctor who should advise the dietary modifications. Which diet is increasing the sugar level? Which dietary agents are good for a diabetic? Which are bad? It's a vast subject. It is a subject more related to a dietitian. But every diet should be flagged as green, yellow, and red zone. Green you can take in plenty, yellow moderate, and red you don't take. Each food has its glycemic index. The glycemic index means the strength of a food to increase the blood sugar level within a time frame. So more glycemic index, more food should be avoided. Less glycemic index food should be given in plenty to these patients. Regular complication monitoring. These patients should be screened for nephropathy, retinopathy before it happens. This patient should have some annual checkups. We will see it in later slides. Self-monitoring of blood glucose is very important. So many times we advise the patient to do the blood sugar monitoring every week or twice a week or thrice a week in type 2. In case of type 1, we have to tell the patient to measure blood sugar 3 or 4 times or more during a daytime. During 24 hours, they have to measure sugar so many times and check the HbA1c every 4 months. And what they do the blood sugar monitoring every 4 or 6 months. This is a very dangerous and hazardous situation because as a clinician, we failed somewhere to explain to the patient what is the importance of regular blood sugar monitoring. The control of BP and lipid. So many times the medias and the newspapers say that BP tablets they do damage and lipid tablets are bad, so they stop the treatment. So educate the patient why the control of blood pressure and why the control of lipids are important with the diabetic control. So what is the goal of the treatment? American Diabetic Association and they say that, and American Congress of Endocrinology, they both have different criteria. The American Diabetic Association, HbA1c less than 7, the ACE says less than 6.5. The preprandial, that fasting 90 to 130 is good. Postprandial, that is 2 hours after the meal, is less than 180 is good. The AC criteria is little bit stringent. HbA1c less than 6.5, FBS less than 110, postprandial less than 140. But make it individualized. If the patient is young, suppose a 25 or 30-year-old patient comes to you without any comorbidity, patient is not having ischemic heart disease, patient is not having history of severe stroke, then this criteria is good. Maintain HbA1c less than 6.5, FBS less than 110, postprandial less than 140. If the patient is aged, he has crossed his prime of life, now he's retired, he's around his 6th decade or 7th decade, then the hypoglycemia will be more damaging than the hyperglycemia. So you keep it a little bit loose control. You keep the HbA1c around 7, 7.5, you keep the fasting around 130, 140, and you keep the ppbs around 160, 180, it's okay. Don't go more stringent than this. So this should be a customized control of each patient. Each treatment protocol, each treatment goal should not be fixed. It should be varying from a person to person according to age, according to patient's CV conditions, according to patient's coexisting illnesses. Now, the complication monitoring. We should do annual eye examination. You will miss retinopathy. The patient will become blind and then you will realize that this patient had a retinopathy. And that is a very important thing to understand, that sometimes the retinopathy runs in the family. If the father had a retinopathy, there are all the chance that son will develop a retinopathy, even with the euglycemia. So something different from the glycemic control is running for these microvascular complications. So many times the patient presents to with retinopathy and the patient is not having diabetes. After a few years, the patient develops the diabetes. Therefore, it's very important whenever the patient comes to you for a treatment of the diabetes, there should be annual fundoscopic examination to rule out or to detect the diabetic retinopathy. There should be annual screening for microalbuminuria. The patient's urine should be tested for microalbumin or microalbumin to creatinine ratio, which is a very good tool to detect the development of the diabetic nephropathy. Feet examination should be done preferably at every visit every third month, so that you don't miss diabetic ulcers or diabetic food changes or the Charcot joints, which are very common in diabetic patients. The BP monitoring should be done every visit you should measure the BP and should see. Even a normotensive diabetic can become hypertensive, so it is not like that you measure the BP only in hypertensive patients. And annual lipid profile, even if the patient is having a normal lipid profile at the time of the diagnosis or at the first visit, it's important that you keep checking lipid profiles annually, so that the LDL rise should be checked and it should be kept below 110 preferably. The frequent self-monitoring of blood glucose to achieve near normal level. As I told you, the SMBG, the self-monitoring of blood glucose is very important. Each diabetic patient, if affording, should have a glucometer at home, so that they can do the frequent self-monitoring. They can keep the tight control, they can detect hypoglycemia early, and they can deal with hypoglycemia at that time. More intense insulin regimen. Suppose the patient is type 1 diabetes, he is on basal bolus, we will see it later on, the multiple daily injection dosage, or if the patient is having type 2 diabetes with nephropathy or some CV complications and the patient is on insulin, these patients will need more intense insulin regimen and they will require more frequent monitoring. Ideally, a patient of type 1 should have fasting, pre-lunch, 2 hour post-lunch, pre-dinner, 2 hour post-dinner, and 2 a.m. late night, 6 readings per day. This is bit impractical, bit difficult, but if possible, there should be 6 reading per day for every type 1 diabetic patient. Now, non-pharmacological therapy is very important because it is one of the important step: the diet, exercise, and treatment. If the patient is not following diet, if the patient is not doing exercise, then your treatment will fail or it will not be much effective. So for type 1, the goal is to regulate insulin administration with a balanced diet. A balanced diet of carbohydrate, protein, and fat is very important for a type 1 diabetic patient, as well as the caloric counting is more important in type 2. In type 1, it's not much important, but there is something called the insulin carb ratio. This is very important. And insulin carb ratio is different for each patient. This is not the topic I am discussing for undergraduates. So this is not important for you, but just remember there is something called insulin carb ratio, a unit of insulin neutralizing amount of carbs. Each food has a specific carb. Suppose you eat a roti or chapati, it has a specific number of carbs, and you have to see how much units of insulin one needs to dissolve or to reduce this carb, increasing the blood sugar level. So the insulin carb ratio is very important in type 1. In type 2, the caloric intake is more important, and as I told you, the glycemic index of food is more important in type 2 patients. Dietitians play a big role, and patients diet should be observed, is tradition should be observed. If you advise not to eat rice to a South Indian patient, then it will be a chaotic. If you advise not to eat bajra or millet to a patient coming from village, it will be a big problem. So a diet advice should be according to the patient's habit or from which background the patient is coming. If one diet chart doesn't fit all, if you give a printed diet chart, you eat this and this and this, that will not fit all. Now we come to the artificial sweetness. So many people are taking this artificial sweetness as a fashion symbol, as a weight losing remedies, but there are some problems. These are empty, what we call empty calories, so it is better to be avoided. But still, so many people don't like bland food. They need some sweetness. They don't like bland tea without sugar. So aspartame, saccharin, sucralose, acesulfame, these are the main available sweeteners in India. Sucralose is sugar-free natura. Aspartame is sugar-free gold. The aspartame has shown a dementia in few cases. This was reported in Gulf War. The army people were taking diet Pepsi and they have some memory problems, so aspartame is better avoided. Sucralose is bit not having much side effects except the flatulence and diarrhea in some patients, particularly a patient who is on alpha glucosidase inhibitors like acarbose and voglibose. The sucralose can create more problem. One of the more natural agent available in India is stevia, but it is little bit bitter. So mostly the patient either take aspartame and sucralose. So look at the content of the sweetener when you are giving prescription. Sugar-free is aspartame, sugar-free natura is sucralose, and sugar-free green is stevia. So the choice of sweetener is on patient's taste. And this is not a treatment. Tell to the patient. Some people think that when they add tablets to the tea, it works as a treatment. Tell them this is for taste. This is not a treatment. Now, non-pharmacological therapy activity, very, very important. Don't become couch potato. Exercise improves insulin resistance, achieve glycemic control. Exercise also checks the endorphins and catecholamines and so many things. Exercise should start slowly for patients with limited activity. It's not like you cycle 1 hour or 2 hours on a first day. You start with 10-15 minutes according to your endurance. You increase your pace and you increase the duration. Patients with CV disease, a patient having history of MI or angina, should be evaluated before starting any exercise. Ideally, a treadmill test should be performed to see whether the patient can tolerate exercise or not. And stop smoking. If the patient is smoking, if the patient is chewing tobacco, then there is no importance of giving treatment to these patients, because these patients are at multifold severe risk because of the diabetes plus tobacco. So the treatment, pharmacological therapy, the role of the doctor now comes the insulin we use in type 1 and late type 2, or type 2 patients undergoing some surgery, type 2 patients having some infections, type 2 patients having some stress, and type 2 patients. There are some studies which have shown that if you give insulin to a type 2 patients initial phase, suppose a patient is diagnosed having type 2 diabetes, and if you give insulin to these patients for a very short time, 2 months, 3 months, and then you stop the insulin and you put the patient on the oral hypoglycemic agents, this patient will remain euglycemic for a longer period of time and might need insulin at a very late stage in life. This is called glycemic legacy. If you achieve the euglycemia early in type 2 diabetes, and if you maintain with insulin for few months, then the patient will not need insulin, will need less tablets as oral hypoglycemic agents for a longer period of time, called the glycemic legacy. We don't go into the details. Other agents are sulfonylureas, biguanides, meglitinides, or what we call the secretalogs, thiazolidinones or the glitazones, alpha glucosidase inhibitors, the new agents like DPP4 inhibitors, SGLT2 inhibitors, and GLP1 analogs. This is a very vast subject. I will be trying to put a separate lecture on each of these, mainly on insulin, but I will just cover the basics here in this lecture. Now, the biguanides are the wonder drugs, the metformin. Initially, the fenformin was in the market and there was a grave risk of lactic acidosis. So, biguanides were not approved by US FDA for decades. But biguanides were used left and right by the Indian diabetologists. And this is the Indian experience which has taught to the world that no type 2 diabetes patient can be treated without biguanides. Fenformin is out. So whenever we are talking about the biguanides, the only drug available is metformin. It is a wonder molecule. We still don't know how it's working, what is the exact mode of action, but this works on cellular uptake of the glucose. So more cellular uptake happens in the glucose. It reduces the insulin resistance. It acts on the muscles. It acts on the liver. It checks the glycogenolysis, and that's why it reduces the blood sugar level. It's a very important drug because it reduces the weight. It is a weight losing drug or a weight neutral drug. There is no weight gain. The second drug is thiazolidinedions, or very easily pronounced glitazones. The pioglitazones and rosiglitazones, they also act at the cellular level, PPAR gamma receptors. They reduce the insulin resistance. There is more glucose intakes inside the cell. So euglycemia or normal blood glucose is achieved by the glitazones. The importance of glitazones is they achieve a very good glycemic control. We will see the HbA1c reducing capacity of each molecule. The glitazones can work wonder, but they take time. They take 1 to 3 months to achieve its full action. They can create problem. There is a too much of water and salt retention there, so the patient with CCF can land up into a pulmonary edema. They can cause bone loss, so they can cause fractures, mainly in females. And long-term use, 15 to 20 years use, there are studies which have shown that these glitazones can cause transitional cell carcinoma in the bladders. So it's a good drug, but has to be used with caution. The sulfonylurea and the secretalogs, they act on the beta cell by sodium potassium ATPase channel. The calcium enters inside the beta cell, calcium calmodulin complex is formed, and proinsulin gets converted to insulin, and insulin is released into the bloodstream. So they act by these channels and they just give more stress to the tired beta cells. Therefore, at some or other time, the sulfonylureas will fail. If they fail at the initiation of the treatment, we call it a primary failure. If we start the treatment and after 6 months or 8 months they stop functioning, we call it a secondary failure. The secretalogs we will discuss in further slides. The alpha glucosidase inhibitors, the acarbose and voglibose, are the molecules. They act at the intestinal level from absorption of the carbohydrates from the diet. So whatever carbohydrates are there, the absorption gets deranged, retarded by these alpha glucosidase inhibitors, and therefore they regulate the blood sugar levels. So absorption, the synthesis of glucose from the liver and muscles, increase cellular uptake, and insulin production increase insulin productions from the pancreas. These are the mode of actions of different diabetic medications. Sulfonylureas, they stimulate the pancreatic secretion of insulin. First generation tolbutamide, chlorpropamide, acetoxamide are out because they have killed more people than they saved. So they are not used nowadays. So we will not discuss this tolbutamide, chlorpropamide, and acetoxamide. The second generation, the glimepiride, glipizide, gliburide. Gliburide is given name glibenclamide in India, and gliclazide. The four molecules routinely used are glimepiride, glipizide, gliclazide, and glibenclamide. Higher potency, less potential for drug interaction and side effects. There are very few side effects. All sulfonate drugs are equally effective in reducing the blood glucose when given in equipotent doses. We will see what is equipotent. But remember, suppose a patient on glipizide is now not maintaining a euglycemia. You are not going to do any magic, or you are not going to help him by putting in on glimepiride. One sulfonylurea failed, all sulfonylureas are useless. So don't switch between one to other. We will not discuss about the first generation. The second generation, the glipizide 10 milligram is equivalent to 5 milligram of glibenclamide, and is equivalent to 1 to 2 milligram of glimepiride, and is equivalent to 40 to 60 milligram of gliclasides. So as I told you, this is the dosage what we discussed, the equipotent dosage. The 5 milligram of glibenclamide is equal to 10 milligram of glipizide, equal to 40 to 60 milligram of gliclazide, is equal to 1 to 2 milligram of glimepiride. This should be given 20 to 30 minutes before the meals, because this will get time to get absorbed, reaching to the pancreas, stimulating the beta cells to produce the insulin, so that the insulin peak should be just falling when the glucose peak happens, when the glucose rises, blood glucose rises after the meal. So ideally it should be given 20 to 30 minutes before the meal. The efficacy of the sulfonylurea, the reduction of the HbA1c is 1.5 to 1 to 7%. Now roughly you can multiply HbA1c by 25 to get the rough blood sugar value. So it is around 50 to 70 milligram of blood sugar reduction. ppbs you can reduce up to 92 milligram of reduction. Suppose a patient comes to you with a post meal sugar of 390, with glipizide you can achieve up to 300. You cannot make it totally normal with only glipizide. Therefore there is a concept of more than one OHA combination, more than one agent combination from different classes. We will see how to approach a case first diagnosed with diabetes with different treatment regimens. But remember, any agent, whether it is a metformin, whether it's a sulfonylurea, whether it's a DPP4 inhibitor or glitazone, the reduction of HbA1c is maximum 1.5, not more than that. When you combine, it can be more. But there has to be a diet modification. There has to be a lifestyle modification. There has to be a stressless life. Then and then the patient will achieve a euglycemia. The adverse effects are hypoglycemia. Sometimes this can be a very troublesome hypoglycemia. Hypoglycemias by sulfonylureas are more dangerous, more prolonged than the hypoglycemia of insulin. This is more problematic when a patient is on other drugs. Like suppose the patient is given quinolone antibiotic for some infections. A quinolone plus sulfonylurea can give you severe hypoglycemia. It can produce hyponatremia. Always remember, mainly the first generation, so we are not much concerned in weight gain. Therefore we are worried. Weight gain will increase, more problems, more insulin resistance, more problems with the syndrome X. So this is not a weight neutral drug. It will increase the weight gain. The short acting secretologues like ripaglenide and nataglenide, these are good molecules because the hypoglycemic potential is less. There is lower incidence of hypoglycemia. Second thing, you don't need to take 20 minutes before the meals. You can just take it with first bolus of meal, or just after the meal you can take this drug. If you don't have a good appetite, if you think I don't want to take some food, then you skip the meal, you skip the dose. Or if you have so this is something flexibility of the short acting secretologues, ripaglenide and nataglenide. Another thing, you have to reduce the dosage, or you have to stop the sulfonylureas when the patient's creatinine is high, when the patient's creatinine clearance or the GFR is around 50, If the patient's creatinine clearance is around 40, you have to reduce the dosage of sulfonylureas, but you can give repaglinide and nataglinide at a full dose because the renal excretion is less with these secretalogs. Adverse effect hypoglycemia, but very low. Drug interaction, the inhibitors of CYP34A and CYP2C9, then you have to remain cautious. The biaguanides, the metformin, ideally this should be first because you have to start the treatment with metformin, and if the patient is not controlled, you have to add other things. So biaguanide is always first line, but just to make it convenient, I put the sulfonylureas as the first place. It reduces the hepatic glucose production and increases the peripheral glucose utilization. A wonder molecule, metformin. One cannot treat the diabetes without the metformin. If there is a prescription of a diabetic patient without metformin, only sulfonylurea, only DPP4, it is not a legitimate prescription. Metformin has to be there at first place. The adverse effects are nausea, vomiting, diarrhea, and anorexia. The diarrhea, abdominal cramps, the abdominal colics is the main problem with the metformin. This is less with sustained release or modified release preparations of the metformin. With the plain metformin, it is more problematic. The fenformin was available in the past, but there were too many cases of the lactic acidosis, so it is banned and it is not available. Now, precaution, metformin should not be used in patients with renal insufficiency. The rule is whenever the creatinine clearance goes below 30, you stop the biaguanides. Creatinine clearance is 140 minus age into weight upon 72 into serum creatinine. This gives you a rough idea of the GFR. If it goes below 30, you stop. If it's below 60, you reduce the dosage. More than 60, you continue giving 1.5 gram or 2 gram to the maximum. But if it is below 60, come down to 1 gram. If it is below 30 to 60, come down to the 500 milligram per day. If it is below 30, you stop the metformin altogether. So creatinine clearance should be measured in each case of diabetes so that you don't miss the problem of metformin dosage assessment in renal failure. The glitazones, the PPAR gamma agonist, they are wonderful molecule. The rosiglitazone and pioglitazone. The controversy of the rosiglitazone, it increases the CV mortality because of the CCF. So it is now out in the market. It was available as 4 and 8 milligram, given as BID dosage twice a day. The pioglitazone is now available. It is in 15 and 30 milligram. Lower the better. If you can give 7.5 best, go up to 15, not use more than 30. It reduces the insulin resistance in the periphery. It sensitizes the muscle, and it also have effect on the liver. Therefore, it is an insulin sensitizer. Therefore, these PPAR gamma agonist glitazones are also used to treat the non-alcoholic fatty liver disease, NAFLD or NASH. Very good results with the pioglitazone. Edema and vein gain are the main problems. It shifts the fat away from the belly towards the limbs. So, the limb size will increase, the belly will decrease. It increases the fracture incidences, particularly in old age patient. The patient who is having compromised LV function, LV is 40%, 50% ejection fraction or less than that, don't use the glitazones because this patient can land up into severe congestive cardiac failure and acute pulmonary edema. The alpha glucosidase inhibitor, the acarbose and voglibose, sound like the Bengali brothers. The pharmacological effect, the NAF effects reduce postprandial blood glucose rise. The peak is retarded. After you eat, there is sudden rise of the blood sugar level. That peak is retarded, becomes flattened, and there is even distribution of the glucose absorption. Most of the glucose or carbohydrate is absorbed from the proximal ileum. Now, when you give the acarbose voglibose, there is even distribution of glucose absorption in the whole intestine. So this peak is not there. There is a gradual rise of the blood sugar level, and that can be very well taken care by the insulin or the endogenous insulin produced, or by the insulin that you are stimulating by the sulfonylureas or other agents. Postprandial glucose is reduced. It has almost no effect on the fasting blood sugar, but postprandial glucose is reduced. FPG is relatively unchanged. Average reduction is 0.3 to 1%. It's a weaker molecule compared to the sulfonylureas and glitazones. In glitazones also you get 1 to 1.5, sometimes more than 1.5% HbA1c reduction. Here you get HbA1c reduction of 0.3 to 1% only. So you do the therapeutic lifestyle changes for a patients with type 2. Initiation of therapy may depend on the level of HbA1c. HbA1c was less than 7, may benefit from the lifestyle modification, but you start the metformin. 8 to 9 oral agent, 9 to 10 more than one. We will see what is the current guidelines. Now the sixth agent is DPP4 inhibitors. Now this was, as I told you before, that whenever a oral glucose tolerance test was done and IV glucose tolerance test was done, it was seen the patients who are subjected to the oral glucose tolerance test, the insulin level or C-peptide level was higher than the IV glucose tolerance test. So the clinicians and scientists thought that there has to be some mechanism in the intestine which is signaling to the pancreas to produce the insulin from the beta cell, and these signals are incretins, the GLP-1. Now GLP-1 are having a very short half-life. Whenever you take a food, the food enters inside the intestine, it is absorbed from the glucose is absorbed from the intestine, the blood sugar is raised. Before that, whenever the blood glucose is there in the intestine, this is detected by the intestinal cells, then they produce the GLP-1. This incretin stimulates the pancreas to increase the insulin and reduce the glucagon. It stimulates the beta cell, it inhibits the alpha cells. Still, it is called GLP-1. This is a misnomer. It reduces the glucagon, but it is a glucagon-like peptide. GLP-1 reduces the glucagon, GLP-1 increases the insulin. This GLP-1 is a very short half-life. It just goes into degradation by a DPP4 enzyme. So, when you give DPP4 inhibitors, popularly known as gliptins, they inhibit this enzyme DPP4 and therefore they increases the half-life of GLP-1. So there is more stimulation of insulin secretions from the existing beta cell. So that means sulfonylureas and DPP4 will only act when there are good number of beta cells in the pancreas. If the pancreas is exhausted, if there are no beta cells, there are no functioning beta cells like in type 1, the sulfonylurea and DPP4 will not act. So DPP4 will need the DPP4 inhibitors or the GLP-1 will need the presence of good number of functioning beta cells in the pancreas. So the incretin of GLP-1 will stimulate insulin release, it will lower blood glucose level, it will inhibit insulin release, and when you give DPP4 inhibitors or gliptin, the enzyme is inactivated and therefore the half-life of the GLP-1 is increased and therefore more insulin is produced from the pancreas. All gliptins, Lina, Sexa, Sita, and more, the drug which is used in India more is 10L-gliptin. You don't need to remember the dosage. You will remember the dosage only after you use it in patients. So at your level, just remember the names. The Lina, Sexa, Sitagliptins, feminine names. So most of the boys will not have any problem remembering. And the 10L-gliptin, which is mainly used in India. Now the SGLT2 inhibitors. Now this is something called accidental discovery. You all must be knowing renal glycosuria. Some of the patients, they have the urine sugar level that is 2 plus or 3 plus when the blood sugar is 110, 120. We call it a renal glycosuria. It is not a diabetic condition, but it is something called the threshold of the kidney to throw out the blood sugar is low. That means the kidney is throwing blood sugar, the urine sugar at the blood sugar level of 120 or 110. These people had a problem or a defensive mechanism at the PCT, proximal convoluted tubule. These are the SGLT2 receptors. And these SGLT2 receptors, if they are less in number or if they are not functioning properly, the patient will throw more glucose out in the urine. Therefore, the concept of SGLT2 inhibitors came into the mind. The SGLT2 inhibitors were developed, they were tried, they were used in diabetic patients. The results were not promising initially, and then gradually the benefit of SGLT2 came out in trials like anything. I don't discuss too much in detail, but I just tell you one thing, that SGLT2 receptors have attracted cardiologists more than the diabetologists, because even in non-diabetic patients, when they use these SGLT2 inhibitors, it has given an excellent result in case of LV dysfunction. How? Because this produces a diuresis, or there are some SGLT2 receptors on the heart also, nobody knows. But the SGLT2 receptor inhibitors have given excellent results in LV dysfunction, and it has reduced the CV mortality also. Now this figure will explain it better. The glucose, it comes out from the glomeruli in the then it enters into the PCT. In the PCT there are SGLT2 receptors. So out of 182 gram glucose which is filtered in a day, 120 gets reabsorbed, 60 gram gets excreted. Now as this load increases, suppose there is 240 milligram, then this will remain fixed. 120 will go inside the blood, 120 will come out. Therefore you get the unit sugar 2 plus, 3 plus, 4 plus. Now what this SGLT2 inhibitor will do, this will be more, this will be less. So instead of 120, this will be around 70 or 80. So more sugar will be excreted inside the urine. So SGLT2 inhibitors, they reduces the amount of glucose reabsorbed by the PCT, and it increases the glucose filtered and thrown out of the kidney. Just remember the names: the dapagliflozin, the canagliflozin, the empagliflozin, the ipragliflozin, the taurogliflozin, rimogliflozin, the sergliflozin. So these are all the gliflozins. These gliflozins, the dapa, cana, empa, they all are SGLT2 blockers or inhibitors. They act at this and they increase the glycosuria and they maintain the blood sugar level. They help in maintaining the euglycemia. Potency is allowing again 1 to 1.5% reduction in HbA1c, but there are added CV benefits as I told you previously. Now this is a very busy slide, but I will try to make it simpler. Whenever a patient comes to you for the first time with diabetes, look at his postprandial level, sugar level, and HbA1c. If it is not much high, if the patient is not very hyperglycemic, you start lifestyle modification, diet, and metformin. Metformin is your first step. Then you tell the patient to come with regular ppbs monitoring or HbA1c after 3 months. If it is not controlled, you add the sulfonylureas. We have discussed the pros and cons of every molecule, so I will not discuss all these things. The moderate risk, the gain, the weight gain, the hypoglycemic potentials, you add the sulfonylurea. Or on the second visit, if it is not controlled with only metformin, you add the glitazones, or you add the DPP4 inhibitors, or you add the SGLT2 inhibitor, or you add the GLP1 agonist. I have not discussed in detail, but the liraglutide and other molecules are there which can be given once a day sub-Q or once a week sub-Q. These are the GLP1 analog which acts like GLP and stimulate the pancreas to produce the insulin. Or metformin plus you add a basal insulin. So on the second visit, if the patient is not controlled with metformin, the options are: initially it was told that you give sulfonylurea, then you add something else. No, now you can give metformin plus SU, or metformin plus glitazones, or metformin plus DPP4, or metformin plus SGLT2, or metformin plus GLP1 analog, or metformin plus basal insulin. Now not controlled, you go on adding. So metformin plus sulfonylurea not controlled, you add glitazones, or you add DPP4 inhibitors, or you add SGLT2 blocker, or you add GLP1, or you add basal insulin. Same way, patient is not controlled with metformin plus glitazones, you add sulfonylurea, DPP4, SGLT2, GLP1. So you play with different molecules and try to achieve normal glycemic control. Now, after all these agents are tried, but still you are not achieving euglycemia, that simply means your beta cell is exhausted. They are not in a position to produce insulin to achieve a euglycemic level. So at that stage, you have to continue metformin and you have to give basal insulin plus mealtime insulin, or what we call the basal bolus regime. We will see it in type 1 in detail. Or you have to give premix insulin to this patient and take away the basal insulin. So metformin plus premix or metformin plus basal bolus is the last regimen which you have to give to these patients. Another theory is you continue giving sulfonylureas, DPP4 inhibitors, SGL2, whatever you are giving with the metformin, and add the premix insulin, because most of the time practically we have seen that insulin only will not act in a type 2 diabetes, because you are dealing with insulin resistance and not only the insulin mania like in type 1 diabetes. In pharmacotherapy, type 1 diabetes, it's easy. It is only insulin. So choice is one, but choice is difficult because there is so much things to learn. Now, always remember the insulin in India comes in two strengths, unit 40 and unit 100. In Western countries, it available in so many strengths, 10 units, 20 units, 40 units, 50 units, 100 units per ml. We are talking about per ml. And whenever the strength is different, the syringe will also be different. We will see it in other slides. So in India, unit 40 and unit 100, only two types of insulins are available. Initially, the bovine and porcine source of insulins were available. Now bovine and porcine are out because of the impurities and causing more insulin antibodies. Now we only have the recombinant human technology insulins available in the market and analogs. We will see it in very brief what is the difference between the two. Now the analogs, the short-acting analogs are Humalog, that is Lispro. Lispro is a generic name, Humalog is a brand name. This is a fast-acting analog. The Aspart or Novorapid. Novorapid is brand name, Aspart is generic name, and regular insulin. This is a hexameric insulin, and we will see the difference between them. The long-acting insulin, the Lente insulin is having zinc, and this forms the insoluble crystals. So whenever a zinc and pH difference, it makes the crystals. So when you give it subcutaneously, these crystals will gradually dissolve. So you will get a little bit of lengthening of the time. So Ultralente and Lente are long-acting insulin. Adding a substance like neutral protamine of hecdone. NPH is neutral protamine of hecdone. This is also a protamine zinc insulin, and this also releases insulin slowly. Therefore, these are what we call a long-acting or delayed-acting insulins, and some long-acting analogs like insulin glargine, insulin detamir, or insulin diglutide. Now, glargine is having a different pH. It is having acidic pH, and it also forms the microcrystals. In case of the glargine and detamir, they also form the crystals which retards its absorption from the subcutaneous tissue, and therefore they are long-acting insulins. In case of the diglutide, it attaches to the subcutaneous tissue just like a velcro. You must have seen the velcro. It gets attached like hook mechanism, and then they gradually gets detached and they are released. So glargine, detamir, and diglutide are long-acting analogs. Lispro and Aspart are short-acting analogs. Lente and NPH are time-tested, old basal insulins or long-acting insulins, and regular insulin is time-tested regular insulin, which we use as a subcutaneous rapid-acting insulin. So, in short, rapid-acting are Lispro and Aspart. Short-acting is regular insulin. Intermediate-acting is NPH and Lente, the old ones, and long-acting are glargine, detamir, and diglutide. So you just need to remember the names, and I will show you a graph to make it simpler. This is Lispro or Aspart. This is regular insulin. This is NPH. This is glargine, and this orange one is detamir. So ideally, these two are basal insulins. Now we all know there are two types of insulin secretions in a body. Basal means a fixed unit of insulin is getting secreted from the pancreas, and bolus means whenever you eat food, there is a peak of the insulin happening. So we want to mimic this basal bolus type of pattern in a body when the patient is having diabetes. Therefore, we are using all these insulins. This ultra short and short acting, that is Aspart, the Lispro, and regular insulins are used as bolus, while the long acting like NPH, glargine, and detamir and diglutide are used as a basal because they will cover at 24 hours, and this will ride as a bolus on that basal insulins. So a short acting will start to work in 5 to 10 minutes. This peak will be 30 to 90 minutes and will stop action in 2 hours. So 5 to 10 minutes starts to work, peak is at 30 to 90, and within 2 hours it will stop. Regular insulin which starts to work in 30 minutes, so we have to take this insulin 30 minutes before the meals. Then in 1 hour it gradually starts peaking. At peak is achieved at 2 to 5 hours, and at the end of 6 hours the regular insulin stop working. The intermediate like NPH and Lente, they start to work after 1 to 2 hours. Peak is achieved at 4 to 12 hours, and it works up to 16 to 80, not 24 hours. The long acting like the glargine, the detamir, the diglutide, they should not have a peak, but they do have a peak. That is the problem. They starts to work 1 to 2 hours, does not have a peak is a false sentence. They do have a peak. The detamir has a big peak, the glargine has a flattened peak, and diglutide has almost no peak. So these are the basal insulins that we use for a long acting, single a day or twice a day. The 3 bolus we use the ultra short acting or short acting regular insulins. Now, the adverse effect is hypoglycemia. Whenever a patient on insulin feels giddy, feels there is a palpitation, feels he is having a tremor, he says that he is having a slurred speech, tachycardia, too much of perspiration, the patient is not having a proper jet band. These are all the signs of the hypoglycemia. If you have a blood sugar measuring meter at home or glucometer at home, measure the blood sugar. If it is less than 60, 70, it is a hypoglycemia. Give oral glucose. Don't wait for the IV access. Give oral glucose. If the patient is unconscious, make a paste of glucose or sugar and put it below the tongue so that the patient doesn't get the aspiration and patient gets recovery from the hypoglycemia. Otherwise, IV dextrose is always best. Initially, in the past, 25% dextrose was used, but it creates so many problems of osmolarity. So now 10% or 5% dextrose is enough to gain consciousness in a patient. 1 gram glucagon, not available in India, but you can get it from outside, IM or IV. This is not sub-Q, remember. You are giving it in an emergency. So he has to be given IM or IV. And it is a big needle, big syringe. You have to give 1 gram intramuscularly. The problem of the skin rash at the injection site. This was more with the porcine and bovine. With human insulin, this is less. Lipodystrophies, and if you don't keep on changing the sites of the injection, ideally the injection site should be changed with every prick. You have arms, 4 fingers left from here, 4 fingers left from here. This is the area where you can keep different locations changing. Same way, 4 fingers from the knee, 4 fingers from your hip, hold the thigh area, you can inject, and 4 fingers away from the center umbilicus, you can inject on the abdomen. So these are the sites where you can keep the changing so that the lipodystrophies does not happen. The problem with the lipodystrophies is that the absorption of the sub-Q insulin becomes totally what we say chaotic. What the dose response you were getting in past with lipodystrophies you will not get. The method of insulin administration, syringes and needles, the good old days, the pen size injections, smart pens are now coming. You can enter the blood glucose in level in the reading inside the pen, and you can calculate the dosage. And so many new smart pens are coming into the market, and the insulin pumps, which are mainly used in type 1 or brittle type 2 diabetic patients. So this is the insulin syringe. Always remember, read this 100 units per ml. This should correlate with your vial. The vial is 100 units, syringe should be 100 units. Vial is 40 units, syringe should be 40 units. Problem is, if the 40 unit vial, you fill it to the 100 unit, the patient will get 40 units, not the 100 units. So always correlate between the syringe and the reading on the vial. These are the pens. The advantage is you can hear the click sound. So suppose the patient is having visual impairity, patient is not able to see properly because of the retinopathy, patient is having reading glasses, then this click sound can, each click will be per unit. So 1, 2, 3, 4. Some of the pens have 0.5 unit increment also. So this they can dial and they can also reverse. Suppose the patient has filled 10 units and the patient doesn't want to take, then they can do the reverse dialing so that the units are not wasted. These are the needles which are used to be attached to these pens. The pen comes into two categories: the disposable pens, which you have to throw when the refill is empty, or the refillable pens where you can use these cartridges. The all types of insulins, the long acting, short acting mix, all are available in these cartridges. You put it in your pen. The principle is, whatever extra cartridges, extra vials are there, you keep it in refrigerator. But whatever cartridges, vials or pens you are using, you keep it at room temperature, away from the sunlight, not in too much heat position. Don't keep the pens or vials which we are using inside the refrigerator, because the cold injections, if you are taking it out, the cold hot will cause the denaturation of the insulin. And second thing, the cold insulin is very painful to take. The needles you have to change every second day or third day. Ideally it should be changed with every prick. Practically we can use for 5 to 6 pricks each needle. This is the insulin pump. Now there are open loop and closed loop system. The insulin pump is not like a computer that you attach and you forget. You have to dial the dosage from here. The basal you can adjust that. I want to take 1 unit per hour. My basal requirement is around 24 to 25 units per day. So I adjust it around 1.5 in the morning, 1.7 in the afternoon and evening, 1 in the late evening, and 0.8 units per hour in the late night. So that I can enter here. So that is adjusted in the that is remembered inside this pump, and it will deliver the basal rate according to that. And bolus you have to take with this pump just like a syringe. It will only give bolus via this needle which is in your subcutaneous space. So it is nothing like that. It will calculate everything and it will deliver by its own, just like a natural pancreas. You have to give bolus. Suppose you are taking 4 units in the morning, 6 units in the evening, 8 units in the night. Then you have to give this bolus according to your carb insulin calculator, and you have to give by this display. The closed loop system works with the CGMS. Few people are using this closed loop system, and it becomes an artificial pancreas. That there is a software, and you incorporate this blood sugar level and your insulin carb ratio, and your blood sugar is detected by the CGMS. It is giving feedback to the mobile or this software, and then it is calculating according to your insulin carb ratio how much bolus is to be given to the patient, and this whole system will work automatically. There is less hypoglycemia and it works wonders. So gradually we are progressing toward an artificial pancreas, but still it's a very large, it is very costly affair. The simple pump with this analog display cost around 3.5 to 2.5 lakhs in India. This pump with CGMS integration cost around 7 to 8 lakhs. The whole closed loop system will cost around 10 lakhs. Each sensor cost around 12 to 1500 if you are using a simple Libre like. With Dexcom, it goes to 2500 to 3000 per sensor, and that you have to change with every week or every 2 weeks. Again, this set you have to change every third day or second day. This is the patch you have by which it is put in the subcutaneous space, and this also has to be changed every second or third day. So whole thing is costlier, but in type 1 it is rewarding. So goal is to balance the caloric intake with the glucose lowering process, insulin exercise, allowing the patient to live as normal life as possible. So in type 1, as I told you, there is a basal and 3 bolus, breakfast, lunch and dinner. So this is achieved by either 1 long acting, 2 long acting, or a premixed or a mixture of regular NPH, plain or regular, and regular NPH. You can do different combinations to achieve this basal bolus type secretion which is happening inside a normal body. So insulin regimen has to mimic the physiological secretion just like the basal bolus in the normal body. With the availability of the SMBG and HbA1c test, adequacy of the insulin regimen can be assessed, and this should be individualized. If a patient is very hectic, very busy corporate life, or a student attending the school, you have to just design the multiple dosage like regular plus NPH or Lente, or 3 Lispro, 1 Glargine, or 3 Lispro, 1 Detimir, or 3 Lispro, 1 Diglutec, or a premix Diglutec with something. Glargine you cannot mix with other insulins because Glargine is having acidic pH, so there will be precipitation. But Diglutec you can mix. There is a mixture of Diglutec and Aspart which is available in the market, which can be given, but premix are better avoided in type 1 diabetics patient, and they should be on basal bolus regimen. So good starting dose is 0.6 unit per kg. So suppose a patient is weighing 50 kg, then it will be around 30 units per kg. Out of 30, 15 should be long acting, 15 should be short acting. So your 15 should be a basal. So either Glargine or Detimine should be 15 units given preferably at the evening, and the 15 units rest should be divided into 3 types depending on the breakfast, lunch and dinner the patient is taking. Suppose the patient is taking less breakfast, then you give around 4 units in the morning, 6 units in the afternoon, and 5 units in the evening. So 4, 6, 5 makes 15. So 15 units long acting and 15 units short as a bolus divided into 3 parts. So more type 1 patients will require 0.1 to 1 unit per kg. If it is more than 1, always think of the insulin resistance in type 1 also. The initial regimen should be modified based upon the symptoms, SMBG, HbA1c and the episodes of the hypo. So as I told you, monitoring of the blood sugar, insulin pump, the collaboration between all works wonder. Insulin pump, as I told you, is a small pump like device. This is a syringe pump. It is a portable syringe pump which is giving a subcutaneous insulin via a set in a subcutaneous space. This is not a rocket science. It requires intense SMBG. Insulin pump without SMBG is totally useless. A patient should be encouraged SMBG and if possible CGMS, that is continuous glucose monitoring, if the patient is on pump. So this is the patch, the needle, this is a polythene needle, the catheter, it goes inside the sub-Q space, that is the release of sub-Q, continuous insulin is released. This is the basal insulin. Whenever the patient eats, the patient enters this bolus unit in this set and then press the deliver switch so that bolus is delivered via this set to the patch and to the subcutaneous base. Surgery. Now the islet cell transplant and pancreatic transplant have been tried and they have given good results. So in the future, we might get a pancreatic transplant in all type 1 patients. Hypoglycemia is the main problem with the type 1 patients. Causes are missing meals. The patient is taken, didn't had good appetite or is not willing to take meal and taken excess insulin, the patient will end up into hypoglycemia. As I told you before, candy or IV glucose or glucagon 1 gram IM is always kept handy. Now we talk about the type 1 and type 2 diabetes common complications. If it is the euglycemia is not maintained, if the hyperglycemia is not checked, if the patient is remaining too much of hyperglycemic, the patient will have a diabetic retinopathy. There will be microaneurysms like this and there will be retinal hemorrhages, exudates, retinal edema. These are the proliferative and non-proliferative diabetic retinopathies. And if not detected early and if the treatment is not given to this patient at time, the patient will end up into a blindness. Nephropathy. If when the microalbuminuria sets in, 30% to 40% of all type 1 patients develop nephropathy in 20 years and 15 to 20% of type 2, they eventually develop nephropathy. Now nephropathy in type 2 is also called the first nail in the coffin because whenever the patient develops microalbuminuria, it means the patient's coronaries are blocked. So it is said that it is poor man's angiography. When the patient's microalbumin is positive or albumin creatinine ratio is deranged, this patient is having nephropathy and this patient's coronary will be blocked and may get myocardial infarction in near future. So it is manifested at microalbuminuria, progressive diabetic nephropathy leading to end-stage renal disease, which was called chronic renal failure in the past. All diabetes patients should be screened annually for microalbuminuria or microalbumin creatinine ratio, tight glycemic control, management of blood pressure. Now, nephropathy also depends on the blood pressure control. If the BP is more than 140/90, the patient can progressively go to the ESRD. So always check the blood pressure, very tight control whenever the patient is going into the nephropathy. The ACE inhibitors and ARBs, they have proved that they reduce the microalbumin, they can also reverse to some extent. So whenever the patient of diabetes is having hypertension, ACE inhibitors or ARBs are the best drug and they are the drug of choice in treating the hypertension and also as a nephroprotector. The neuropathy, loss of sensation due to damage of the nerve fibers, heat, cold, pain, the glove and stocking types. This can cause anesthesia, hypoesthesia, or paresthesia. The patient will feel a pain or pricking like sensation, or a patient will feel like walking on the cotton roll because of the diabetic neuropathy. So many mechanisms are there. I don't go into the detail because it will form a single lecture of 1 hour to discuss about the neuropathy. But it is mainly the increased orbital level inside the neurons, as well as the glycation end products, advanced glycation end products called the AGEs, which causes the neuropathy. There is autonomic neuropathy, which is manifested in diabetics as orthostatic hypotension. So I will always advise to take the patient's blood pressure in sitting as well as in standing position in diabetic patients so that you don't miss the orthostatic hypotension. The diabetic diarrhea, the what is called the diabetic gastroparesis, the erectile dysfunctions and difficulty in urination. These all are because of the neuropathy. The peripheral vascular disease and foot ulcers, the gangrenes, the diabetic foot ulcers, these are the dreaded diseases. This is because of the ischemia, because the vessels are not supplying proper blood because of the atherosclerosis. Peripheral neuropathy, the insensitive skin, the patient doesn't feel the pain, and secondary infections. Because the immune system is compromised, there will be no proper healing because of the glycations of the collagens and the poor wound healing. This all leads to the secondary infections, gangrene, and foot ulcers. So uh, gestational diabetes I will just cover here, because as I told you, the diagnosis is the gestational diabetes definition is diagnosis of diabetes in the pregnancy. Diet control, blood glucose should be monitored by insulin. Some of the trials have shown that glibenclamide can be used, but still we are skeptical about using oral hypoglycemic agents in pregnant diabetic patients. We mainly use premix insulin or short-acting, long-acting analog combination in gestational diabetes patients. But if the gestational diabetic patient was having polycystic ovarian disease (PCOD), then metformin, which the patient was taking as a treatment protocol for PCOD, should be continued when the patient gets pregnancy. We have discussed in detail about the diabetic ketoacidosis, so I don't go into the detail. But whenever a type 1 diabetic patient misses a dose or go under some stress, emotional stress or surgery or infection, the patient can land up into diabetic ketoacidosis. It is an emergency and should be treated immediately. That ends my this presentation on diabetes. I tried to remain as simple and as short as possible. If there are any questions, then you can please post in the comment section below. Thank you.